Okay, welcome to the first inaugural ISCL webinar, When Things Go Wrong, Respectful Management in the Aftermath. This is a very exciting day for us at the ISCL Knowledge team. This is our first webinar and we are delighted to be joined by such an expert group from around the globe. My name is Tim Shaw. I'm the Director of ISCL Knowledge and I look forward to viewing this presentation with you. We will be recording the presentation so you can see it at a later date. Now, I'd like to introduce the moderator today, who's Dr. Karen Luxford. She's the Director of Patient-Based Care at the Clinical Excellence Commission in New South Wales, Australia. Karen is also the convener of the Patient-Centered Care community on ISCL Knowledge. And I do hope you have a chance to go to ISCL Knowledge. That's www.isclknowledge.org. And you can join Karen in a number of activities around patient-centered care on that community. Without further ado, I'd like to hand over to Karen, and I'm sure we'll all have a great experience over the next hour. Thank you.
Thank you, Tim. And I'd like to introduce our three fantastic speakers today. We're lucky enough to have with us Jim Conway, Rick Iedema, and Marty Hatlie. First speaker is going to be Jim Conway. Jim is an adjunct lecturer at Harvard School of Public Health in Boston and is Principal of Governance and Leadership Group at Pascal Metrics in Washington, D.C. in the U.S. He's also a Senior Fellow at the Institute for Healthcare Improvement in Cambridge. Rick Iedema is a research professor and director of the Centre for Health Communication at the University of Technology, Sydney. His research explores how communication impacts on the organisation, the quality and safety in care. And Rick's going to be talking to us about some of the work that came out of his study, the 100 Patient Stories Project. Marty Hatlie is currently CEO of Project Patient Care, which is dedicated to fostering improvement in the Chicago area in the US. He's also president of the Partnership for Patient Safety. He co-founded Consumers Advancing Patient Safety, and he also serves with the World Health Organization's Patients for Patient Safety Steering Committee. So we have a fantastic range of people with us today to talk about the most important topic of when things go wrong, respectful management in the aftermath. I'd like to also acknowledge that this has drawn interest from all around the world, and we have people from all walks of life. It's wonderful to really see the variety of people that we have involved this morning. We've got people who are consumer advocates themselves. We have lawyers, we have clinicians, we have people working in policy, we have academics. So it's fantastic to see that variety. I'd like to now hand over to Jim Conway, and Jim's going to be talking to us this morning about leadership response to a sentinel event, respectful, effective crisis management. Thanks very much, Jim.
Well, thanks very much, Karen. It really is a great honor to be here today with the ISCL Knowledge Patient-Centered Care community. I personally love these global calls when we get to do them based on who's talking and who's listening. It's yesterday, today, and tomorrow all at the same time. The Institute for Patient and Family-Centered Care has outlined 4 key concepts that really make up the foundation of patient and family-centered care. And the 4 concepts are dignity and respect, information sharing, participation, and collaboration. The goal is that these are applied certainly not only at the good times, and I know as a healthcare executive that all over the world, every day, there is extraordinary care, caring, hope, and discovery. But these 4 concepts are also applied at the bad times, in the suffering, the harm, the tragedy, the waste, the death that goes on in our healthcare system, also worldwide. In the United States, in the last year, we confronted a very sobering reality in a report out of the Office of the Inspector General of the Department of Health and Human Services. They told us that every month, 6,600 senior citizens die of preventable deaths. These are our mothers, fathers, sisters and brothers dying in the aftermath of unnecessary harm. When these events happen, I'm quite sure to all of the people on this call, the next thing that happens is somebody calls us and says, Jim, it just had a horrible error in the ICU. Something just happened that never should have happened. What do we do? As a person who's received hundreds of these calls, I am struck at the horrible burden of the call. The person calling me, often the CEO, is devastated. They're in tears. I am struck by the similarities of the stories. No matter what you tell me, I've heard it before. I am floored that people are calling, but not surprised. They're calling with a blank sheet of paper. They're making it up as they go along. Their response is highly reactive, it's unbalanced, and in all cases, they're underestimating the potential harm to everybody involved. In 2010, IHI brought together a very large community. We brought it together with a goal. The goal was that in the aftermath of a serious adverse event, the patient, the family, the staff, and the community would say we were treated with respect. Many of the people involved in that community were part of this call that we're having today. What we learned as we prepared this white paper that you see on the screen is that the steps that have to be taken in the aftermath of great tragedy are pretty well known to us. The first step is to avoid the crisis in the first place. The second is to prepare to manage the crisis. We can't make it up as we go along. We then need to recognize that we're in crisis. We need to contain the crisis, resolve the crisis, and then profit from learning from the crisis. Why don't we move to the next slide? We also learned in this process that there's very specific things we need to do, whether we're doing it for the patient, the family, the staff member, or the organization. The first thing we have to do is be empathetic. We have to meet the patient or the family where they are. We have to say, I'm sorry, not us over whether or not this was preventable or not. It's just to sit down with that mother and say, I'm sorry, I'm devastated that your child is dead. We then disclose what we know. We provide support. That patient may have gone in the hospital for an outpatient procedure. Now the family is in the second week of an ICU stay. How are we providing support in the place of certainly unanticipated harm? Then we need to do an assessment. They want to know what happened, why it happened, and what's being done to prevent it from happening again. Then, based on that assessment, there needs to be an apology. One of the things that we're learning is that people are doing a dramatically better job with apologies, but they're forgetting the next steps. How do we bring it to resolution? And that may include compensation. how do we provide for learning, and how do we assure that there's improvement in the aftermath of these events. So again, whether we're talking about the patient, the family, the staff, the last thing the staff wanted to do was to hurt somebody that day, or the overall organization, each of these steps is necessary. Let's move on to the next slide. As we prepared the white paper, what we identified was a foundation of policies, procedures, practice, and a culture that must be in place in order to build the respectful crisis management going forward. It includes everything from a culture of safety, the conversations you have with your malpractice carrier, the policies, the practices, the guidelines, the flows that are in place. One of the things that I knew as a leader of the Dana-Farber Cancer Institute was whether an adverse event happened at Children's Hospital in Boston in their cancer program, at Dana-Farber, or at the Brigham and Women's Hospital, I knew that within 30 minutes of that being identified, I would get a phone call. Why? Because we didn't make it up as we went along. When a call came into risk management from one of the patient care locations, risk management had a flow sheet they took out, and the first person that they needed to notify was me. I, in turn, had a flow sheet, and the first person I notified was the CEO of the organization, and the second one was the vice chairman of the board. And you can see other elements in this. Let's move on to the next slide. And in the next slide, you will see a crisis management checklist that we have put together to support organizations as they go through these events. Are these events different? Absolutely. But what we've learned is there's very specific steps that apply in virtually all cases. The first, you got a plan. The second, you have a system of internal notification. The third, in the spirit of never worry alone, you bring together a crisis team which is activated. The next, you focus on the three priorities. The first priority is always the patient and family. The second one is the staff. And the third is the organization and the larger community. You have a program for adverse event management. You have a system for communications which is focused not only externally, but also internally. So people know when a patient comes in to one of your staff and says, so what's going on? Your staff doesn't say, I don't know. They don't tell me anything. Instead, your staff is able to take out a piece of correspondence that came directly from executive leadership and show them what they've learned. You also have thought about reimbursement and compensation. And then finally, you are preparing for external notifications to regulatory agencies as well as the visits from regulatory agencies. I continue to be surprised at the number of people who are shocked when the accreditation agency arrives at the door of the organization. So in the resources and many, many more that we have put together in this white paper, we have assembled an approach that we believe will lead to respectful management of serious adverse events. While the response to this work has been pretty remarkable, since it was released in late 2011, the second revision of this, we've had 45,000 visits to the white paper. We've had over 78,000 visits to the content. 15,000 people have downloaded the white paper. We're seeing presentations around the world. Just recently, we have seen it cited in new guidelines being issued both in the radiology community as well as in the American College of Obstetrics in guidelines. As I bring the call to, and this part of the call to a close, I want to mention a few closing thoughts. The first is this white paper will create awareness. But awareness is just the first step. The second step is we have to change individual beliefs and attitudes, and then ultimately that will lead to changes in our actions and behavior. Bishop Desmond Tutu said, if you take my pen and say you're sorry, but you don't give my pen back, nothing has happened. But Bishop Tutu is reminding us in all of this work, there is a focus on repentance, learning, and improvement. I end with the quote of the CEO of the Mount Auburn Hospital in Cambridge, Massachusetts, who in the aftermath of a great tragedy, Jeanette said, when something goes wrong, it is how the organization acts that redefines and reshapes the culture. Thanks again, and I look forward to the opportunity for further questions now and in the future.
Thanks very much, Jim, for that great insight. I wanted just to ask you a question. We've got a lot of questions coming through on the chat at the moment, but I thought in compensation, or is it an apology? And people might be concerned that offering compensation might actually just offend. What are your views about that?
Well, I think the complex answer is a very simple answer. It depends. I think what we have to do is meet the patient or the family where they are. So let me tell you a very personal story. In August of 1980, I was working at the radiology department at Children's Hospital in Boston, and I took a call from my sister Maureen, and on the call she said, Jim, I think you better come home. I think Dad is dead. My father that day had gone to receive health care in the organization where my sister worked. And our organization, our family ultimately found out that my father's death was probably quite preventable. When his death happened, our family was outraged, obviously, and took a very focused approach, led by my mother, to understand what happened, why it happened, and what was going to be done to prevent it from happening again. We met with the leadership of the hospital, and for a whole bunch of complex reasons. He was a retired cop. We were influential in health care. An investigation was done. And then they met with us to tell us what happened, why, and what was going to be done to prevent it from happening again. Sister said we could sue if we wanted, but my mother said no, it won't bring John back. But you know, when my father died, the day he died, so died his pension. My mother lost all income associated with my father with this preventable harm. It would have been remarkable then, and it certainly is happening today, to have, if somebody had come over, put their hand around Marie and said, Marie, how can we help? Back to the opening of this, I believe we need to meet patients and families where they are. In some cases, people will want compensation. In some cases, they won't.
Thanks very much, Jim. I'd like to now turn over to Rick Iedema, and Rick's going to tell us a bit about the patient and family's perspective of when things go wrong. Thanks very much, Rick.
Contextualize it a little bit, and James, if I could have the next slide here. I should just say that, first of all, just waiting for the next slide. Thanks, James. In 2003, the Open Disclosure Standard was published in Australia, and this was a groundbreaking document at the time. It was followed up with a pilot to see to what extent the standard could be taken up into actual clinical practice. The pilot was subsequently evaluated between 2006 and 2008. And as part of that, we interviewed 131 clinicians around the country, as well as 23 patients and family members. And what we found was that everyone was supportive of disclosure, but many people pointed to concerns and challenges. Then the summary of this evaluation went to ministers around 2008. They endorsed the principle of disclosure, meaning that all states in Australia then were to write disclosure policies. And the ministers also felt that we hadn't really spoken to enough patients' family members, and they thereby charged the Australian Federal Commission on Safety and Quality in Healthcare, who funded this work, to fund another study to find out what patients and families were actually thinking of the developments that had been put in place with this new policy. And that's what produced the 100-patient story study. There's a couple of references at the bottom there of the screen, which are the two main papers that have come out of this work so far, and I should here acknowledge in particular Dr. Helen Allen, who was very forceful in making that project happen. And just to outline the main findings of this work, James, if I could have the next slide. In the first instance, what people told us, and we talked to 119 people over 100 interviews. Some interviews had more than one person. A lot of the interviews were done with family members because patients had died. What many people told us was that few incident disclosures are done in ways that actually satisfy them. And the main issues that people talked about were actually things like inadequate preparation for the disclosure, such that, for example, a clinician would come up to a patient at the bedside and say, oh, by the way, something has gone wrong. And people not having the time to prepare questions, not people having the time to prepare themselves for the news, and people being left with all sorts of concerns without there being much opportunity for follow-up. Inappropriate disclosure was another thing that people commented on in terms of sometimes the story changing from one person to the next. So that first point, that few incident disclosures were actually done in ways to satisfy patients and families, was a critical outcome of this study, and that points to a lot of work still needing to be done in this particular domain. What people felt, and that's the second point on the screen, is that the principal reference point for services and clinicians after an incident is their legal liability and reputation, rather than the patient or the family, respect and openness. And this is what is really quite remarkable about Jim and his team's IHI Whitepaper, where the first priority is the patient and family. And that is something that the people that we talked to really thought is a principle that needed to be brought home. Thirdly, it was really interesting to find out through the in-depth interviews that we did with these people that they have quite a lot of knowledge about and insight into the incidents that happen to them. And also, they often have ideas about what needs to be done in response. They have ideas about solutions. They have ideas about what the service needs to do to prevent similar things from happening again. And we've written about that too in the second paper that you saw listed on the previous slide. The problem there, though, and this is point 4 on the screen, is that patients and families feel that they're rarely invited to contribute their knowledge. Again, I should refer to the IHI Whitepaper, where on page 14, Jim and his team actually make the point that patients and families might be invited to join the RCA investigation in whatever form that might take place. But that is an important point to make, because often patients and families who have been there when care unfolded know things that can be critical to the team doing the investigation. Lastly, we were fortunate enough to speak to people who were allowed to have input into the clinical work and into improvement that services sought to make following an incident. And these people were able to make critical contributions. One example I'd like to give before closing is of Diane, who was able to say to the clinicians of the ICU unit where her husband died that the vasopressin overdose was not really the incident. The incident was the junior staff not listening to her or her husband when he was still on the ward and missing all sorts of information that led her husband, the patient, to be shifted into ICU where this incident was allowed to happen. The clinicians who heard this said, you're right, we need to look at the incident in a much broader framework, and this is something that radically changed the shape of the root cause analysis investigation that occurred around this particular case. The second case example is of Alicia Wood, who lost her baby in a neonatal intensive care incident due to a transportation failure. Alicia has been able to work with the service where this incident occurred and make sure that diaphragmatic hernia babies who need surgery now have a survival rate of in the 90%, as opposed to, as was originally, 50 to 60%, which is an enormously big difference, but also, as Alicia says, an enormously satisfying outcome for her and something that is much more important than going to counseling and doing other things that might not have led to this kind of practical effect. This is really a very, in a nutshell, overview of the 100-patient study findings. I refer people to the papers if they're interested in finding out more, or they can email me. Thanks, Karen.
Thanks very much, Rick. The insights from your study are really important to us all, and thanks for detailing those. And obviously there's more information in your publications. We've just popped up another poll, and I wanted to ask you a question, Rick, about whether you've got a sense from the work that you've done about how we can better integrate patients and families' input into that dialogue about what went wrong. Did you get an impression from your work about that?
We certainly did, because patients and families were so concerned that that particular aspect was improved. People wanted more dialogue about what went wrong. And there's three things that people told us. One is to do with preparation, one is to do with practice, and the last one is to do with psychology. Preparation is about making sure that patients and families have a number of opportunities for providing feedback, whether that is through on-board comments that are acted on, a phone message service, whether that's an app even that people could access, any kind of feedback system that enables people to get real response. That's the preparation side. The practice side, people could think about, in health services where things go wrong, about visits to patients' homes, for example. If patients are interviewed in their homes, they remember all sorts of things and they can say all sorts of things that may not be possible to be said in a hospital context. And it's critical that people feel that they are comfortable and able to say exactly what it is they need to say in response to things that are really quite traumatizing. With regards to psychology, the third thing, and this is about blame. Of course, when things go wrong, patients and families are very angry. They can be very angry and they can be very blaming of people. Clinicians need to be very resilient in the face of this kind of blame and anger. They need to have this largesse that enables the clinicians to actually absorb those emotions and not use those as a legitimating reason for saying we're not going to talk to patients and families because they're obviously angry and they're obviously going to sue. Instead, what needs to happen is a far more sophisticated kind of approach that says to patients and families who know that you want to blame and that you're angry, we're going to work with you on enabling you to understand the complexity of our practices, to enable you to understand also how it is that this incident came about, and to get you out of that situation of blame and anger.
Thanks very much, Rick. We've had one comment on the chat line about the importance of the acknowledgement of accountability. And another from Donna Davis, thank you, about indeed the point that we were just making, that without that patient and family perspective, you really haven't got the complete picture. Thanks very much for that, Rick. I believe our poll is still up, so it might have just disappeared. Oh no, it's come back again. You have an opportunity to give us your views if indeed you have experienced an adverse event or have a family member who has, whether you are asked for input into what it was that went wrong. We'd like to change gear a little bit now and move over to Marty Hatlie. Marty is going to talk to us about moving beyond apology and thinking about how do we actually engage patients and families in the improvement piece. Thanks very much, Marty.
Sure, Karen. I'll just echo what Jim and Rick said before me. It's a great pleasure to be here and to participate in this conversation. So next slide, please. Okay, so I've been tasked to really talk about patient engagement and moving beyond apologies. And the real challenge with patient engagement, and I think it comes from a kind of a fear and discomfort that we have whenever we try something new or think about trying something new where there's no evidence. And so that's the major sort of hurdle we've got to get over, is that there really is no evidence in the scientific or medical sense of the word that engaging patients in safety and quality improvement actually improves things. I like to point out, however, to people that aren't engaging patients that there's no evidentiary position for their position either. I mean, we really have evidence that engaging patients causes harm. It's just the traditional position, the normalized position. So there's no real reason to hold on to the current practice. We do have some questions that I value and I think is important to think about from the engineering perspective, and that is a fear, a caution, that there's so much variation amongst patients, so much variation amongst families and their support structures that it's hard to imagine, honestly, when giving them jobs or giving them roles for which they have some kind of accountability or responsibility for contributing to safety. So we take that caution and we move forward. What we do have is a lot of evidence from the chronic care world that when patients do take on a job in their own care, they get better outcomes. So we're kind of extrapolating from that. We're encouraged by that as we think about how to engage patients and what opportunities to provide them. The other thing that we have to deal with as a challenge is the real fear of assigning responsibility to patients or families. And this really comes from the patient advocacy side. People who fear that whenever they hear providers talking about engaging in a way that creates, a job for patients or a task for patients, that there's some sort of attempt to shift responsibility or assign responsibility that's behind that sentiment. And Jim and I actually heard quite a bit of that in our work with the Joint Commission as we got to certain places where we were thinking about what patients could do. This fear raises itself, and I think we also have to acknowledge it. Where we do have clear evidence is that patients consistently report a desire to see change. I mean, this is true in 15 or 16 different studies, everything from opinion polls of patients and families to structured interviews to studies of disclosure to very powerful stories. It's highly, highly consistent. People want to see their experience mean something, count for something. They want to see it lead to change. And I think that is the nugget of what we've got evidence for, and I think it gives us a good starting point for thinking about patient engagement. And then that is, let us offer opportunities to the patients and families that want to be engaged. Let's let the wall down. Let's ask them. Let's invite them in to be a player in our safety and quality improvement work, or frankly in the safety of their own care or the care of the loved ones they're managing. And we'll see. I mean, not all patients will want this responsibility. They'll not all want to kind of take this invitation or this opportunity, but I think some will. And that's kind of the point of innovation that I think we're at. So if you are an innovator and you do want to engage patients more, let's move to the next slide. What we know so far from the hospitals that have really gone forward and done this is that they report good results. And hospitals that engage patients are happy about it. They learn things that they did not know. I think Rick just spoke really thoughtfully to that, and Donna Davis chimed in as well. I mean, there are things that you only learn from patients and their families. You cannot learn it from your other sources of input. They also learn about unexpected attitudes and feedback. When you engage patients, we realize that we presume too much what they're thinking or what they're feeling especially after an adverse event. We project, for example, in our country, in the U.S., that everybody is a potential litigant, that everybody wants to litigate when they've had an adverse event, and nothing could be farther from the truth. Most patients and families that I've talked to do not want to litigate. They feel like that's one of their only options for getting at the truth or for figuring out what happened, the kinds of gaps in conversations that they want to fill in that, again, Rick and Jim talked to are being so important to them. So you just see the compensation issue that Jim raised. I mean, I think we, on the provider side, kind of assume that after an event, most people are going to want compensation. When in fact, there's a whole range of things that people want. And when we open the door and listen to them, that's what we learn. The innovators also report culture change, especially when conversations start early after an event. Many report increased trust because they're talking about the hard things. There's a relationship that's actually stronger, and there are several, really powerful stories out there to this point. Providers also report kind of a self-affirmation. They feel better about themselves because they're doing the right thing. They're acting in concert with their deeply held ethics and values. And we see that kind of, deeply held reaction really influence organization behaviors and organizational structures. So we see more disclosure. We see people building and trying new things to engage patients, having different kinds of conversations, building patient input into advisory councils or board committees or something like that. So it really is a source of important culture change. And what I like about it is it's kind of existential in the sense that by doing these things, you actually become patient-centered. So being more patient-centered is an article of rhetoric for us. We all want to do that. We all sort of have that in our mission statements now. But actually by honestly communicating, by engaging patients in this kind of work, or at least giving them the opportunity to engage, we're actually realizing that model that we want to be a part of. So that's kind of what we know from the innovators. And what I would say really to all of the people from the healthcare side of the equation that are on this phone call is that there are important vectors that you should be paying attention to now. And the first is that patients and patient advocates increasingly are going to ask for the opportunity to be involved. So if you're not offering the opportunity, believe me, you're going to be asked for it. Some people will stand up. They've become informed consumers. They're concerned. They've got information. They've talked to friends. They know what it's like. They're frequent flyers in the healthcare system, so they know what it's like, and they're going to want to be engaged. Again, a personal experience of mine in 2009 and 2010, I had two parents in the healthcare system, both with cancer, one of whom was clearly in remission and gram-negative, and the other one who didn't, who was failing. And we had a lot of family dynamics to manage, and we approached healthcare providers and said, we need your help in putting together a plan. I mean, we've got this big challenge on us. Our parents one of them is staying alive for the other. And we got incredible responsiveness from the staff. And when I debriefed with them later and said, why did you spend so much time with us? Why were you so open to us? They said, because you asked. And they essentially shared with us that they didn't know how to approach every family because they're worried about the variation. They don't know how to start the conversation. When a family starts the conversation, they'll respond. And that's probably the chief piece of advice I now give to the patients and families that I talk to start the conversation. You might find providers being more responsive than you realize they'll be, than you think they'll be, or that you anticipate they'll be. But I also turn that around to physicians and hospital administrators and nurses and others on the phone. And when someone asks you to become more engaged, it probably isn't confrontational. It probably is a desire to be engaged, and I mean, it really is an opportunity for you to have a very, very meaningful, I think, journey with this patient. The other new vector I think to really pay attention to, at least in this country, I'm not sure how this is playing in other countries, is that we're giving increased weight to patient satisfaction in our payment calculations. So as we calculate reimbursement for hospitals and physicians, how well patients report being satisfied is going to become an increasingly larger percentage of what's weighed in those payment calculations. So we're finally beginning to have a business case for patient engagement. By engaging patients, if we know that they want to be involved, if we know they want change, showing them how we're making that change, showing them how we're involving them. The article is based on my part at this point in time, but I think that's going to increase their satisfaction, increase their trust. And it's nice to see the business case developing for that. Next slide.
That's it, Marty.
Oh, okay. Okay, Karen. I thought I had another one, but why don't we stop there and see if you've got any questions?
Yeah, thanks very much, Marty. And one point of clarification I'd just like to make is when you talk about there not being evidence for patient engagement, I think we've got good evidence around improving patient-centered care in terms of improved outcomes. So I think we need to make that distinction. I just wanted to also mention that when Rick Iedema talked about Alicia Woods a little bit earlier, it's been a wonderful interaction for us at the Clinical Excellence Commission to also have Alicia Woods working with us on projects at a state-based level to improve patient safety and quality. So I think patients can work at a service level and they can work with national, international and state organisations as well. So that's fantastic. We've got a number of comments and questions that have been coming in on the chat. I think a very poignant one from Josephine Chulo, who makes the point that when we're trying to improve things in our community for people in different groups, such as disabling, making that point, Marty, but does it strike you as strange that the end users are not so involved in healthcare?
Yeah, it does strike me. I mean, there's a lot. I've also kind of thought on a point that you made too, and that is the connection between patient engagement and patient-centered care. As you know, I'm the head of the coalition here in Chicago that is trying to get all of our 90 hospitals. We have 90 hospitals in our region, which we're a huge market, to be thinking differently. And we probably have 4 out of the 90 that are actually engaging patients. I would say a huge number of those hospitals feel and are doing things that they think of as patient-centered care. But it's for the patient. It's really provider-centered. It's listening to the patient in some new ways. I don't mean to discourage it. It's important. But it stops short of engagement. It's not really giving patients, the invitation to come in and work with us on this stuff. It's a commitment to be doing things for them, but not necessarily with them. And I think that is an important frontier here, is that, that with piece. So I just want to kind of make that kind of counter to your clarification, because I think it really is an important thing for us to keep talking about as we move forward. Mm-hmm. And now I've lost track of your question.
The other piece was from Josephine, which is the strange contrast between what we do in healthcare and what happens in other communities in terms of engaging the group affected or the users, and how we don't have such a strong history of doing that in healthcare.
Yeah, I mean, it is. It's a normalized kind of behavior. Again, I think it comes from this place that we do it for you, but not with you. I mean, I think square one engagement is just listening. It's realizing that disclosure is not a process of talking only to the patient. It's also listening to where they're coming from, and that's fundamental bottom line engagement. That's relationship that builds. Mm-hmm. And then the structural things that we could do that I think are kind of what other organizations do. I mean, if we're going to produce patient education materials, we get consumer education materials, we get consumer input into what those materials are. We engage consumers through focus groups or other kinds of research in doing that. I think the rule in healthcare is still that we, think, oh, we know what patients need. I mean, we talk to them every day. We'll just kind of put together this material, this brochure, and the next thing you know, you have a brochure that says, beware of mirth, it can cause complications. With that complications word going right over the heads of most people. And the kind of caution that I see in many patient education materials about making the patient and family alarmed or worried or fearful about how dangerous the hospital is, when, you know, the reality is that patients and families increasingly understand that hospitals have a lot of safety work to do, and that, you know, it's right to be cautious. So closing those gaps can be closed if we just improve this dialogue, and there's many ways in which hospitals can be, and the innovators are starting to do it. But it's, you know, again, most of that journey is before us. And I couldn't agree with Josephine more that that journey is still mostly before us.
Fantastic. I just want to open this up for the speakers now because we've had another number of other questions coming in. Just to build on a comment from Bart Windrum, excuse me, Bart has made a comment about the meaningful use of words and language and the difference between what the language that clinicians might use in an incident versus what a non-clinical audience of patients and families might use. And just to build on that, a question I might direct to you, Jim, that's come to us from Anne Axton, is about how do you select the right person to talk to families when an incident has occurred? Should it be the people involved in the incident, or should it be someone else? What are your thoughts?
I think initially it should be someone else. In part, as soon as we exclude the people who were close to the incident when it occurred, then it looks like we're focusing on who did it and not what happened. And there's nobody who was closer to what happened for an incident where a chemotherapeutic agent was being, cisplatin was being administered to a patient who had been on a 10-year chemo cancer journey. And the physician forgot to auto hydration, and the patient had just disastrous kidney renal implications. The physician couldn't bring themselves to talk to the patient because after 10 years he failed this patient. So it was how did we support the doc to come in the room together with another person and the patient and have the conversation. It would have been disrespectful to have somebody from risk management fly in and have that conversation when there had been a 10-year relationship. What did the patient say to the doc? Doc, they've been through a lot more worse than this over the last 10 years. We'll figure it out together. And the two of them did. So I think we have to provide support to people, but we can't have a Don Quixote that flies in to save the day and not respect the relationship that between the patient, the family, and the clinician that has gone on for years.
Thanks very much, Jim. Perhaps, Rick, you might be able to comment. We've had a question from Lisa Morose about training for patients in terms of what sort of support do people need to be having these sort of conversations, and do we need to make them aware that a serious event may be a possibility? Are we just frightening people?
Is that I think people are now expecting more to be told about the real risks that they're facing going into healthcare. We're dealing with an increasingly educated population, and even though health literacy is still an issue in many places, people do expect to be talked to honestly, and people have now shown this across cultural backgrounds that this is the case. The other issue about this is that if something goes wrong, if we ask the patient or the family, that they are immediately given some documentation about what this might entail, and the Australian Commission on Safety and Quality in Healthcare has now put together a booklet. So it's a very brief little booklet that says if something goes wrong or if there's an unexpected outcome, then these are the kinds of things you need to think about. Support person, some questions you may like to think about, the kinds of people that you'd like to talk to, and so forth. And that's kind of preparation of people to start thinking about healthcare not being like stuff you get on television and ER or House or whatever, is, I think, something that people are now increasingly expecting.
Thanks very much, Rick. We've got some good dialogue going on the chat. I'm hoping that everybody can see that, and some links to publications that are relevant, and also some work that's happening in Australia through the Australian Commission for Safety and Quality in Healthcare, revising its standards on open disclosure. So I think that we can see that this is an area that's internationally of interest. I was wondering if I could just ask the speakers in closing what sort of investigation. We know that root cause analyses and investigations occur within facilities, but how do you engage the patients in that piece and have a frank conversation? Rick, you might want to let us know what people in your study thought was appropriate.
Yeah, it goes back to that issue of psychology, really. People are obviously disappointed, if not angry, and perhaps blaming in response to something going wrong. And they feel that if they do not go into a conversation completely self-controlled and generous to the clinicians as what happened a priori, that there is going to be great difficulty in persuading the clinician or the service to be open and honest. And I think what needs to change now is that the clinician or the person who represents the service is able to be generous enough to allow people that emotional upset, perhaps the anger and the blame, and work through that to get people to understand the full complexity of the incidents that they've experienced. It is that complexity of care that patients and families very often do see as being part of the care, but also need to talk about with their clinicians to be able to understand its role in things not going always as expected. I think that is an absolutely critical component here of furthering the conversation between patient families on one hand and clinicians on the other hand, for whom it is very often about technical details, a very narrowly defined incident, and issues that are outside of the immediate experiential domain that patients and families bring to this whole thing. For patients and families, it may be to do with the nurse who told them something that they were upset about or something that wasn't listened to. It is these kinds of starting points that I think was made reference to earlier, that people will need to begin with. Start with where the patient and the family are at and work out from there.
Thanks very much, Rick. I'm going to start to wrap us up now, and we'll see some of the poll results on the screen soon. Thanks, James. I'm wondering if Marty or Jim, you would have any concluding comments as well.
I guess just to build on Rick's point, the most frequent question I get from patients and families for comments is, the hospital told me they were going to do a complete investigation, but nobody talked to me. And so open that line of communication. I mean, I think patients and families will understand that perhaps you can't share all parts of the RCA process with them, but do interview them, do include them, do follow up with the communication. And I mean, I think that's a very basic, respectful thing that will be really important in terms of maintaining trust in a relationship if that's possible.
Thank you. Jim, did you have a final comment?
Just very much agree with Marty and Rick. Build an interview with the patient and family into the RCA process. It's not sitting around the table necessarily in the actual RCA meeting, but there is it's the way we do the work is that they're included as part of this process. Otherwise, the process doesn't make sense to somebody. So I just, on my BlackBerry, received an email from a patient who was incensed that the organization has issued their finding and hasn't spoken to them.
Thanks, Jim. Well, that's a poignant place to end. We've put the results of the poll into the chat box if you want to have a look at those now. Do you have a crisis management plan? 25% yes, 20% no, 2% under development, 4% unsure, and no answer for 49%. So I think we've got room for improvement there. I did see the second poll up on the screen a little while ago, and I think the majority of the responses were no in terms of were you, if you'd experienced an adverse event, were you asked for your views, 30% no, 8% yes. So thank you very much for that input. I'd like to sincerely thank Jim Conway, Rick Iedema, and the ISQA Knowledge team who've done a wonderful job of producing this webinar. I know that they're going to record it so it'll be available for others. So thanks very much to Tim Shaw, Alexis Hilbury, and to James Nicholson. So thanks very much for joining us, and we hope that you'll become part of the patient-centered care community on ISQA Knowledge, and that you will also be engaged in our community and be involved. Goodbye, everyone.
Thanks, Karen.